Paul Kalra, Mike Gibson coming to you live from AHA 2022, and we are talking about one of the hot studies here, the IRONMAN study. You know, I didn't really realize just how many patients out there actually have an iron deficiency. A lot of people say anemia, but it's different than anemia, right? It's more of an iron deficiency that we're talking about here.
Absolutely.
Yes.
I think that's a really important message to get across, that the impact of iron deficiency on patient well-being, so associating with impaired quality of life, reduced exercise capacity, greater risk of heart failure, hospitalization and death, is independent from whether you're anemic or not, or the level of hemoglobin. So absolutely.
So checking what values identifies these people, ferritin levels, or what are you looking at?
So we're usually looking at two distinct parameters. So ferritin, a ferritin of less than 100 in chronic inflammatory disease like heart failure or chronic kidney disease is defined as iron deficiency. However, because of the pro-inflammatory state, we often see ferritins above 100, so you can still be iron deficient. So we use a transferrin saturation of less than 20%.
I see. Great.
So either or.
So you identified those people, and they had an EF less than 45%, then you randomized them to talk to us about this IV iron treatment that you used.
So this was building on data from a compound called Ferric carboxymaltose that had been shown in studies out to 24 weeks. It could improve exercise capacity, quality of life. And then
24 weeks.
24 weeks.
Not 6 months, not full 1 year.
Absolutely. Yeah. And then there was one study called Affirm AHF where hospitalized patients with heart failure were treated pre-discharge, treated repeated dosing as necessary out to 24 weeks, followed up to a year, and there was a reduction in the risk of rehospitalization. Our trial was different. We used a different iron product called Ferric Derisomaltose. It's a drug that you can give in high dose according to the patient's body weight and hemoglobin, and so you try and get total body replacement in a single infusion wherever possible. We randomized patients 1-to-1 in a probe design, so an open label trial, given some of the challenges of having a masked or double blind study with a dark intravenous compound. So usual care versus intravenous iron, and we followed the patients at 4 weeks, 4 months, and then 4 monthly, with the patients in the intravenous iron arm being redosed if ferritin was less than 100, or if TSAT was less than 25%. And we used a higher cut for redosing in an attempt to maintain iron repletion for as much of the study as possible.
And what did you find?
So we found it, well, it's a study that spanned 2016 through to 2022, and in the UK we got hit pretty hard by COVID. We had periods of national lockdown from March 2020, and so we had quite considerable periods where patients couldn't come up to be assessed for iron deficiency and redosed as necessary. So as part of this, we've got the main analysis, but we've also got a COVID sensitivity analysis, which is censored at all the patients randomized March 2020, which is 91% of the cohort, tracked for another 6 months, because our clinical experience is that once you've corrected iron deficiency, it's unusual or less common to need redosing in 6 months. So for the main cohort, which was 1,137 patients, the primary endpoint, which was recurrent heart failure hospitalizations and CV death, the rate ratio was 0.82 with a p-value of 0.07. When we look at the COVID, pre-specified COVID analysis, we have a rate ratio of 0.76, so 24% relative risk reduction with a p-value meeting conventional statistical significance of 0.047. Something else that's in our trial, the usual care arm, the protocol did not permit intravenous iron. However, over the median follow-up of 2.7 years, we found that 17%, or about 1 in 6 patients, were given intravenous iron at some point, which we will have diluted the treatment effect.
So when you take the totality of the data, what do you think? Is this ready to really be used in clinical practice broadly?
I think it's very important to assess these trials building on the other evidence, the totality of data, correct? So I think that the double-blind studies that have looked at the short-term effect on patient well-being for patients, a very important outcome. I think is convincing. And I think the AFFIRM-AHF, the IRONMAN trial together, the magnitude of benefit was very, very similar in both in the overall analysis and the COVID sensitivity analysis. The chances of both of those happening by chance is extremely low. So I think it adds a lot of support to incorporating the assessment of iron deficiency in regular clinical practice. If you don't look for it, you're not going to treat it. And then when present, I think we can now confidently discuss with patients the potential impact on well-being. And the harder endpoint is primarily reducing the risk of heart failure or hospitalization. The other thing that IRONMAN adds with 2.7 years median follow-up is the safety data. There were no signals of adverse safety. And I think that's something that we've been missing with the 24-week treatments in the past.
Exactly. Great. Well, thank you. Great job. Thanks for joining us. Thanks to all of you for joining us here live from AHA 2022.